Today, we're going to have the last of our COVID-19 webinars for 2020. We've had this series since last June. Sara, Curran, Giovanna, Merli, Jenn, Dowd, Pam Hurd, and I have worked on putting this together. Today's a really good day. We're starting to get some interesting results from studies that have been done over the last 6 months. And the topic for today is the mortality impact of COVID-19. So we're going to have 3 papers, and each paper is going to be about 17 to 20 minutes. After the paper, there'll be a time 2 to 3 minutes for specific questions. And then we expect to have about 20 minutes at the end of the webinar to have general discussion on the topic of mortality and COVID. We would like people who are attending to put questions in the Q&A box as the webinar proceeds. And Giovanna and I and Sara Curran will monitor questions, and we will read the questions to the participants. If you are directing it to a specific person and it's difficult for us to tell who that is, then indicate the person to whom you're directing the question. So at this point, both Theresa and Noreen are able to speak. And on the second paper, Andrew, Irma, and Sam Preston are all able to speak. And on the third paper, Christophe will have to do it all by himself. So we're going to begin with the paper by Theresa Andrasfay and Noreen Goldman. Theresa is now with me at USC. She's been sent to work with us after working with Noreen as a pre-doc. So Theresa, why don't you share the slides?
Great, then I'll start. Thank you, first of all, for inviting us to present our work. And as you can see from this slide, we'll be presenting 2 papers. The first of which Theresa will present, is available on the Health Sciences preprint server and hopefully is about to be forthcoming. The second paper, the one on Native Americans, is still in very early stages and there are very preliminary results. And it's a paper co-authored with 2 students of mine, Katherine Leggett-Barr and Fumiya Uchikoshi. So if we go to the next slide, before turning the first part of the talk over to Theresa, I wanted to briefly motivate these 2 papers. So they deal with several racial ethnic groups, Black, Latinos, Native Americans, all of whom have borne a disproportionate amount of COVID-19 morbidity and mortality. These groups have gotten a fair amount of attention, both from academics and mostly, I'd say, from journalists. The problem is, in many cases, the mortality rates for these groups have been presented by very simple kinds of measures, which ignore the age structure, ignore the fact that all of these groups, Black, Latinos, and Native Americans, are considerably younger than whites. And of course, as we all know, that presents a serious bias. The other issue that's specific to Native Americans is that most of the estimates that we've read about in papers are really for Native Americans, in particular reservations. And almost all of the studies in that case are from journalists rather than academic researchers. In the case of Blacks and Latinos, we actually have the data, and it seemed critical to us to move from these very simple measures to life table kinds of measures, to life expectancy at birth. I mean, clearly we're demographers, and that's the way to measure the impact of COVID. Moreover, there's been such a huge focus by demographers, other researchers, the public, in the last few years on what's happened to life expectancy in the US. The fact that it's gone down for 3 consecutive years, 2015, 2016, and 27, by 0.1 of a year, Now that number really strikes us potentially as very small. It was not very small. It was a very unanticipated decline, one that was affiliated with deaths of despair in many cases, and focused on the decline being concentrated in whites. And it was followed by a lot of press again that said in 2018, the last year for which we have these data, life expectancy at birth rose by 0.1 of a year. And so it's a natural question to say, how does COVID-19 compare in terms of its impact on life expectancy? So I'll turn it over to Theresa, and she will give me the floor, so to speak, again when she's done.
All right, thanks, Noreen. So in our analysis of life expectancy, we set out to answer 3 questions. First, we wanted to estimate what the projected impact on 2020 life expectancy at birth and at age 65 would be due to COVID-19. Second, what are these impacts for the white, Black, and Latino populations in the US? And third, how will these impacts affect racial and ethnic disparities in life expectancy? So we use a variety of data sources to do these projections. The first is that we need an estimate of the total number of deaths in 2020 due to COVID-19. And so we take the projections from the Institute for Health Metrics and Evaluation from the University of Washington. We use the projections that were issued on October 9th. At the time, they estimated that the medium scenario would have about 321,000 deaths by the end of the year. And as of now, that medium estimate is pretty similar. They estimated a higher mortality scenario in which mandates continued to ease, and that projected just under 350,000 deaths. And they estimated a lower mortality scenario of 276,000 deaths that assumed that everyone in the population would wear masks. Just to orient you today, we reached 250,000 deaths. So we are almost at the lower mortality scenario. The next data source is provisional death counts from the National Center for Health Statistics. And this allows us to have a distribution of COVID-19 deaths by race, ethnicity, and age. Next, we take 2019 mid-year population estimates by age, race, and ethnicity from the Census Bureau, and the 2017 life tables for the total population and separately by race and ethnicity provided by the National Vital Statistics System. So moving on to methods, we have standard demographic methods that allow us to take an all-cause life table and imagine what would happen if we were to eliminate one cause of death to create a cause-deleted life table. And here we want to do essentially the opposite. So we treat the 2017 life tables as cause-deleted life tables in which COVID-19 is the cause of death that has been eliminated. Then we use those methods to recover the all-cause life tables for 2020 that includes COVID-19 as a cause of death. We do so separately for each race and ethnicity under consideration and each of the projection scenarios. In order to do this using the available data, we needed to make a few assumptions. The first of which is that in the absence of COVID-19, the mortality conditions in 2020 would be equivalent to those last observed in 2017, which is the most recent year for which we have the life tables separately by race and ethnicity. The second assumption is that the cumulative total numbers of deaths by the end of 2020 will have the same racial, ethnic, and age distribution as the deaths that have already occurred. And then the last assumption is that individuals who do not die of COVID-19 in 2020 are subject to the same mortality conditions as in 2017. And I'll discuss later the implications this assumption might have. Moving on to results. So this first graph here shows life expectancy at birth under 2 scenarios. In orange, we have the absent COVID-19 scenario, and in blue, we have the COVID-19 medium scenario. So here we can see that for the total population, the life expectancy at birth is projected to decline from 78.6 years to just under 77.5 years, a reduction of 1.13 years. When we disaggregate by race and ethnicity, we see very different impacts. From a life expectancy reduction of just under 0.7 years for whites, we see that it's 3 times that for the Black population at a 2.1 year reduction, and over 4 times that for the Latino population at over 3 years reduction. This panel on the right shows similar results, but for life expectancy at age 65. Just as with life expectancy at birth, we see substantial racial and ethnic differences, ranging from 0.63 years for the white population all the way up to 2.24 years for the Latino population. One thing I'll note here is that while we don't do a formal decomposition of the ages that contribute to these reductions, you might notice that for the white population, the reduction in life expectancy is quite similar at age 65 as it is for life expectancy at birth. And this is consistent with the fact that the majority of deaths for this population have been at older ages. In contrast, we see that the reductions at age 65 for the Latino and Black populations are both smaller in absolute magnitude and proportionately smaller. And this is consistent with the fact that they've experienced more deaths at younger ages. This graph puts these declines in the perspective of life expectancy increases over the last 40 years. So here we see that for the most part, life expectancy has generally been increasing, although there have been some transient declines. But we see that the declines projected for 2020 are larger than any single year life expectancy declines over this period. They're quite dramatic. In particular, the decline expected for the total population would reduce life expectancy to a value last observed in 2003. And for the white and Black populations, it would reduce life expectancy to one last observed in 2004. And just to note, we can't separately disaggregate Latinos prior to 2006. So our last goal in this paper was to estimate what the implications for racial and ethnic disparities would be. The orange line here shows the Black disadvantage in life expectancy relative to whites. And so as you can see, it's negative because they've had lower life expectancy. But since the 1990s, this has been increasing or getting closer to zero. But for 2020, we see that that trend is expected to reverse, and the Black-white life expectancy gap will increase by 40% under our medium scenario. In contrast, the Latino advantage relative to whites has been increasing since it's been measured. But again, due to their large projected reduction in life expectancy in 2020, this is projected to decline by over 70%. For the sake of time, I won't get into the details of our alternative scenario results. I'll just mention that under the higher mortality mandates easing scenario, the reductions in life expectancy at birth are about 7% larger. And under the lower mortality universal mask scenario, they're about 12% lower. So to summarize, we project that COVID-19 would reduce life expectancy in 2020 by over 1 year for the total US population, which is larger than any single year reduction observed in the last 4 decades. But there are substantial racial and ethnic disparities in these impacts. The impact on Black life expectancy at birth is 3 times that for whites, and the impact on Latino life expectancy is over 4 times that for whites. Deaths at younger ages contributed proportionately more to life expectancy reductions for Black and Latino populations than they did for whites. And these reductions are projected to narrow the Latino advantage relative to whites and increase the Black-white disadvantage. We consider a few potential explanations for this higher mortality burden among Black and Latino Americans. On the one hand, there's likely higher exposure to COVID-19. Black and Latino Americans are more likely to hold frontline jobs and jobs at high risk, which results in higher exposure at work and in commuting to work. It's also been suggested by the media that a higher prevalence of intergenerational households might result in more spread of the disease. And then there's also been reports and studies of higher mortality for those infected in these populations. It's been suggested that a higher prevalence of some comorbid conditions could increase mortality for those infected. And then we know that there are persistent inequalities such that there's reduced access to care and lower quality of care for these populations. As I mentioned earlier, our calculations are based on several assumptions, the most consequential of which is that we assume that individuals who do not die of COVID-19 in 2020 are subject to the 2017 mortality conditions. This would be violated due to excess mortality from other causes or unattributed COVID-19 deaths, which would make our projections understate the true impact on life expectancy. This may be counteracted to some degree if there's a high degree of selective mortality of frail individuals who would likely die anyway, or reduced mortality from other causes. But given the huge extent of excess mortality, we believe that the most likely impact is that our projections are an understatement of the true impact on life expectancy, making our estimates conservative. And I just want to note that this situation is rapidly changing. We call these projections rather than forecasts, so they shouldn't be taken as a definitive prediction of what will happen. So just to conclude this part, I'll note by saying that no living cohort is likely to experience a reduction in life expectancy. This is period life expectancy. But at the same time, we think it's unlikely that life expectancy will rebound to the pre-pandemic trend line for a variety of reasons, including how long it takes for the vaccine to get approved and widely distributed, and issues with uptake. There could also be long-lasting health effects for those who recovered, disruptions to other types of medical care, and health impacts of the current recession. So I'll turn this over to Noreen.
Okay, thank you, Theresa. So let me just take the last few minutes to talk about a paper, a very preliminary paper I mentioned with two of my students, Katherine Leggett-Barr and Fumia Ushikoshi, that's looking at results for Native Americans, where the problem is complicated by a severe lack of data, and when you have data, very small sample sizes. So we look again at death rates for COVID-19 and risk factors compared with other groups. So the first slide here, Theresa, if I could get you to, thanks. Looks at, in this case, we have to move away from life tables. We don't have life tables for Native Americans, but what we recognize is that we need to standardize death rates. So we look at crude death rates in the upper part of this panel and indirectly standardized by age and by county rates in the lower part of the panel. This follows a procedure described by Goldstein and Atherwood early on in the pandemic. And what you can see is these are relative rates for each of the three groups, Latinos, Blacks, and Native Americans, each time compared with whites. There's a huge increase going from crude rates to standardized rates. That's not a surprise to any of us at this point. But what's really striking is, despite what we've just seen through Theresa's description of very high impact on mortality for Latinos and Blacks, and indeed the standardized rates are twice the rates for whites. For Native Americans, we're talking about rates that are 3 times that of whites. Okay. The next slide says, how about if we look at this across states? These are states that as of the summer had at least 20 deaths in a given ethnic group and at least 20 deaths among Native Americans. And what you can see, the basic story here is that the variation across states is huge. South Dakota, 16 times the death rate of Native Americans. Oops, can we go back? Native Americans compared to whites. In Mississippi, 13 times the death rate of Native Americans compared to whites. And in other states, much more modest relative death rates of Native Americans compared to whites. And that indeed is part of the goal of this paper, to understand why there's such huge variation across the states in the death rates from COVID of Native Americans. Okay, the next slide is a scatter plot. I realize we shouldn't go ahead and do correlation coefficients on ends of 9 or 10. This correlation coefficient happens to be about 0.9. But the issue here was simply to look at, within each of these states, what % of Native Americans lived on a reservation versus what was their relative death rate compared to whites, all with this indirect age place standardization. And what this, first of all, I should mention that this counting how many Native Americans were on reservations was a very tedious task that my student co-author, Katherine Leggett-Barr, spent a lot of time doing. And what you can see from this is that the correlation is very high. And what it suggests is that important risk factors for COVID in this population are very likely associated with living on a reservation. Okay, and the final slide, just to show you a few numbers that we've been gathering. So we've gathered estimates from two surveys, the American Community Survey and the Behavioral Risk Factor Surveillance System. Both of these are large enough so that we can get down to a state level and look at Native Americans, who are a relatively small group. We've pooled many years. We have these data for the US that I'm showing you. We also have them for the 10 states that I showed you. The point I want to make here is that many of these likely risk factors are far worse among Native Americans than even they are among Latinos and Blacks. For example, the percent who have health insurance, excluding the Indian Health Service, which is notoriously inadequate for health provision, is, you know, as bad for Native Americans as for Latinos. It's lower and lower than the other groups. The level of poverty, or in reverse, the income poverty ratio, is worse for Native Americans than for any of the groups. The percents living in 3-generation households for Native Americans are higher than for whites and Blacks, a little bit lower than Latinos. Very high smoking rates, larger than all the other groups. Very high diabetes rates. These are all risk factors for COVID. Very high obesity rates, a little bit below Blacks, considerably higher than for whites and Latinos. And when we look at a range of health conditions, they perform worse on most of them. Okay, so as I said, this is very preliminary. We're gathering the same data for states. And at this point, I want to thank you for listening to both of us.
Noreen, we're not hearing you.
Oh, okay, so I'm done. I mean,
and the paper on Native Americans, why standardize on county? This is from John Haga.
Okay, so I mean, we were following the advice of Goldstein and Atherwood in the sense that infection rates vary enormously across place. If it turns out, for example, that Native Americans are heavily concentrated in areas that just had very high infection rates, that could make a difference. That's also part of the logic always of comparing them to whites, on the assumption that everyone is subject to higher COVID rates when infection rates are high, although there's segregation in whom you interact with. But let me mention the following in response to John's question, which is the indirect standardization by age has a much bigger impact than by county. So we would have the same results essentially if we didn't do it also by county.
Really interesting.
And there was another question in the chat box. It asks you to clarify, given the difference in age structure between the Latino population and the white population, how do you account for this in the calculation of life expectancy due to COVID, loss due to COVID?
Okay, so let me let Theresa take that.
I can answer that one. So one of the benefits of using these life tables is that we can create these summary measures of life expectancy that are sort of, we call them age distribution free. And so we're able to account for that. And these are sort of simulated measures where we take all the mortality rates of a given year and subject a hypothetical population to them. And so with this method, it doesn't really matter what distribution the actual living population has in terms of age, because the simulated population, we can control for that across the different racial and ethnic groups to get this one measure that doesn't depend on the underlying age distribution. Hope that helps.
And a question from Elizabeth Thompson. How much do you think the potential reduction in influenza and the COVID restrictions might influence the results?
I mean, I don't know how much have they in the past, how much will they for the rest of the year? I mean, in terms of for the rest of the year, our projections take into account, to the extent that IHME gets it right, which they haven't consistently done in the past. I'd say at this point, you know, we have actual deaths through some point in October. So most of the deaths will have occurred as opposed to being part of a projection. So the question is, how much difference will it make over the rest of the year? Right now, their projections say modestly. My guess is they're underestimating it a bit. Theresa, do you want to add to that?
Not sure. I think it's possible that influenza reductions would reduce mortality somewhat, but I don't think it'll be to the extent that it would really change the results. And it certainly, in my opinion, wouldn't change the disparate impacts that we see.
Yeah. Oh, sorry, I was answering that more for COVID rather than influenza, but I agree with you. I think in terms of influenza deaths, they are dwarfed right now by COVID deaths.
All right, thank you. I think we should move on to the next paper now. So Andrew Stokes is going to present this paper, and you want to share your screen, Andrew? It's assessing the impact of COVID-19 pandemic on US mortality, a county level analysis.
Okay, thank you
Good.
for having, yes, can you hear me?
Yeah.
Okay, thank you for having us. I'd like to thank Eileen, Sara, Giovanna, Jenn, Pam, and Bobby for organizing these events and for inviting us to present. This is a close collaboration with Dielle Lundberg, Katherine Hempstead, Irma and Samuel Preston, and institutionally between Boston University, Penn, and the Robert Wood Johnson Foundation. I will talk today about the concept of excess deaths, about the different types of excess deaths, how many excess deaths have occurred, what do we know so far, what is known about inequities in excess deaths, and gaps in the literature in our approach. Then we'll move to research questions and hypotheses, methods, findings, and briefly wrap up with limitations, conclusions, and next steps. So in background, excess deaths are typically defined as the difference between the observed number of deaths in a specific time period and the expected number of deaths in that same time period. It is a useful measure for circumventing some of the issues with cause-specific mortality data that as demographers we're all well aware of. So this is a convenient metric that can assess the total burden, the mortality burden of the COVID-19 pandemic without relying on cause of death data. So we think about excess deaths associated with COVID in terms of directly assigned deaths, and then excess deaths that were not assigned to COVID-19. And in that category, we can think about misclassified deaths that were ascribed to a different cause inappropriately. And then there are indirect deaths that may be due to the social and economic consequences of the COVID-19 pandemic. In thinking about this, these categories, we owe to the demography community, folks like Andrew Neumer, who early on in the pandemic put a lot of thought into developing these different categories. So the direct tallies of COVID-19 deaths are those reported by Johns Hopkins, the New York Times, and others. As of November 17th, there were 248,000 directly assigned deaths. And the JHU dashboard does a great job breaking that down by state and county and other aggregations. With respect to these misclassified deaths that were ascribed to other causes, the CDC keeps a real-time tally of excess deaths by cause, and some of these may be so-called misclassified deaths. So we're seeing a large increase in excess deaths related to Alzheimer's disease and dementia. We're seeing some excess deaths in circulatory disease, as well as in diabetes and other causes. So some of these, again, may have been misascribed to these other causes when in truth, the underlying cause may have been COVID-19. Of course, there are also indirect deaths, which would be deaths due to the social and economic consequences of COVID-19. The CDC put out a report on ED visits in the early surge of the pandemic and documented a 42% decline in ED visits in that period. The top 20 categories with lower visit counts during the early pandemic period included musculoskeletal pain, included diabetes, and several other categories that are, alarming and concerning in terms of the consequences of not seeing an emergency physician for those conditions. So we also have data on outpatient visits in 2020 relative to the same week in 2010 and 19. This graph at the bottom was developed by the Lerner Center at Syracuse, and they show a very alarming dip in outpatient visits over time. Fortunately, it appears to have rebounded in the early summer, but now that we're in another wave of the pandemic, we may expect to again see decreased utilization with potential medium and long-term consequences for indirect deaths. So how many excess deaths have occurred? Probably the so-called gold standard right now estimates are from Daniel Weinberger and colleagues at Yale. And they estimate that approximately 22% of all excess deaths through 5/30/2020 were not directly assigned to COVID-19. This is another set of estimates by Stephen Wolf and colleagues. This is another, let's say, another best guess at the true totals. And in this paper, Stephen Wolf and colleagues were even able to break it down by state and to show how the pandemic evolved over time and the extent to which the excess deaths were, in the early days concentrated in states such as New York and New Jersey. And in the later period in the summer, those excess deaths moved to states like Texas, Florida, and Arizona. So we see a shifting kind of evolution of the pandemic over time with respect to geographic patterns. What is known about inequities and excess deaths? Less is known about inequities and excess deaths, but nationwide, Black people are dying at 2.1 times the rate of white people. And we have new centers, including the Anti-Racism Center at Boston University, which is putting a lot of effort into tracking these patterns and showing very alarming inequities across socioeconomic status and race and ethnicity. We also have good data from the UK, from the ONS and others on socioeconomic patterns of COVID-19 mortality, showing that the socioeconomic gradients in COVID-19 mortality are even more accentuated or marked than the associated patterns in all-cause mortality. So gaps in the literature and our approach. The primary limitation of prior work is that the use of aggregated national and state level data has made it difficult for researchers to examine inequities and excess deaths. We really want to be able to drill down to different subpopulations that are hardest hit by the pandemic, and that's been hard to do with these aggregate level data that are published and available so far. So our approach is to use county level data and area level measures as a proxy for demographic and structural factors. Our questions include what are the total number of excess deaths associated with the COVID-19 pandemic to date, and how do excess deaths not directly assigned to COVID differ by demographic and structural factors. Our hypothesis is that racial and socioeconomic inequities in COVID-19 mortality are underestimated by direct death tallies. We hypothesize that this would be the case because disparities in testing and higher rates of comorbid conditions may lead to less accurate cause of death assignment in some groups. Structural racism in healthcare may lead to more indirect deaths due to insurance, access to care, location of care, past experiences at healthcare facilities. We also believe that there may be disproportionate social and economic consequences of the COVID-19 pandemic in certain groups due to increased rates of stress, food insecurity, evictions, loss of employment, social isolation, and loneliness. And the work that Dr. Crimmins and others are doing to integrate COVID measures into surveys like the HRS will be really important for teasing these out. Methods. We take advantage of spatial variation in COVID-19 mortality across US counties to estimate its relationship with all-cause mortality across all counties. We anticipate that counties with higher mortality from COVID-19 will also have experienced greater increases in mortality from other causes of death because the impact of the pandemic is not registered in COVID-19 deaths alone. Therefore, we use the relationship between COVID-19 mortality and changing mortality from all causes of death to estimate excess mortality not directly assigned to COVID-19 as a cause of death. And then we examine how the extent of excess mortality not assigned to COVID-19 varies across subsets of counties. I should say that Dr. Preston and colleagues have a long history of driving attributable fractions indirectly for smoking, obesity, and other conditions, such as the Preston-Glide and Wilmuth method. So we can think about the methods that we've developed here as kind of a continuation of these earlier work on smoking and other conditions. So here's our model. We modeled the death rate from all causes in County I in 2020 as a function of the average death rate from all causes historically over 2013 to 18. And then we have an indicator of the COVID-19 death rate in County I in 2020. The value of beta 1 represents the extent to which past levels of all-cause mortality in a county are replicated in 2020. Combinations of the intercept alpha and beta 1 indicate how mortality changes not associated with COVID-19 vary with all-cause mortality in 2013 to 18. And the value of beta 2 is kind of our key quantity of interest. It indicates the extent to which mortality from COVID-19 affects all-cause mortality in 2020. So you can think about it as the multiplier, which gives us an estimate of the kind of the undercount. NCHS, the National Center for Health Statistics, provisional county level data on all-cause mortality and direct COVID-19 deaths from February 1st to September 23rd, 2020 is the data we're using. The data set is limited to counties with 10 or more COVID-19 deaths. The NCHS, Bob Anderson's group, the mortality branch of the NCHS, is doing a huge service to our community by releasing weekly files with updates. And so, although these are only today's estimates are updated until September 23rd, we do have the ability to update these in real time. We constructed a historical comparison period using CDC Wonder data from February to September 2013 through 2018. We used county level demographic and structural factors from the RWJ County Health Rankings. We used US Census population estimates for 2013 to 2018, as well as for 2020, and we weighted our models using the 2020 county population. We appreciate the US Census Bureau for providing us with additional information for our denominators. Thank you to them. And to identify counties where excess mortality was higher or lower than predicted in our model, we calculated the residuals from our model and examined the residuals across deciles of county level factors. So here's the data set as of September 23rd, 2020. These are counties in the United States with 10 or more COVID deaths, direct COVID deaths. You can see that there's still major gaps in terms of representation. But of course, this map is evolving rapidly over time, even between September and now. Unfortunately, it's not a good thing. When we have more data, in this case, that's not a good thing. That's very alarming. But here is our kind of descriptive data where we relate the all-cause death rate in 2020 minus the rate in 2013 to 18. So those are our kind of excess deaths. And we look at the association of excess deaths with direct COVID-19 deaths. If all the observations fell on the 45-degree line, that would suggest that there's no uncounted or let's say hidden deaths due to COVID-19. But in our case, the overall slope of this line suggests that there is a positive multiplier, that the COVID-19 death rate is associated with increased all-cause mortality. Here is our model estimates. We conducted several sensitivity analyses, which are also displayed here. Given the observed range of 2013 to 18 death rates, the combination of alpha and beta 1 in our model implies that when COVID-19 mortality is set to 0, all-cause mortality is expected to have risen in all counties between 2013-18 and 2020. The value of beta 2 suggests that for every 100 deaths assigned to COVID-19, the number of all-cause deaths rose by 136. In sensitivity analyses, we repeat our analyses using negative binomial regression models and indirectly age standardized death rates. But in our primary analyses, we keep it very simple. So here's our kind of key finding when we apply our regression estimates to absolute numbers. For every 100 deaths assigned to COVID-19, the number of all-cause deaths rose by 136, with a confidence interval from 124 to 147. That means that 26% of all excess deaths were not directly assigned to COVID-19 on death certificates. So that gives us 183 directly assigned deaths, 65,000 excess deaths not assigned to COVID, for a total of 249 total excess deaths. And I should say that this is just based on our sample of 1,000 counties, and therefore the estimates would be even greater if we were speaking about the nation as a whole. So here are our findings with respect to demographic and structural differences. Our residuals measure how our model predictions compare to the actual number of all-cause deaths in a county. We examine subgroups of counties organized by deciles of county level factors, and we ask whether there are fewer than expected deaths, negative values, or higher than expected deaths, positive values. So for example, counties with high income inequality and high percent non-Hispanic Black had higher than expected numbers of excess deaths. In our residual analysis, we also looked at differences by state, and we find that states in the South and the Midwest tended to have higher than expected number of excess deaths based on above what the model would have predicted. And overall, just to summarize, the county level factors that were most associated with increased excess deaths not assigned to COVID included high income inequality, high percent non-Hispanic Black, low percent homeownership, high population density, and Midwestern and Southern states, suggesting a pattern related to structural racism and socioeconomic disadvantage in terms of where these hidden or invisible or uncounted deaths are occurring. We also compared average death rates in counties with higher versus lower median household income and income inequality and percent non-Hispanic Black. This is a decomposition analysis, so we're showing deaths in the absence of COVID, so the counterfactual in the absence of the pandemic, and then we add in the directly assigned deaths to COVID-19 and then the additional deaths not assigned to COVID-19. And what we find is that the difference in mortality by household income inequality, and percent non-Hispanic Black grew when we considered direct COVID-19 deaths and excess deaths not assigned to COVID-19. We repeated this analysis using indirectly age standardized death rates in a sensitivity analysis, and the differences are even bigger. The bottom line of this graph is that existing inequities are underestimated when we don't take into account COVID deaths, and also when we don't take into account the misclassified and indirect deaths. We also applied that same logic to our county data set as a whole, and we found that the standard deviation of mortality across counties increased by 9.5% as a result of excess deaths directly assigned to COVID-19, and the standard deviation of mortality increased by an additional 5.3% as a result of excess deaths not assigned to COVID-19. So again, using direct COVID tallies leads to an underestimate of the extent of the inequities across population subgroups. So limitations. We're using provisional all-cause and direct COVID-19 data for 2020. Some counties that are currently reporting lower all-cause mortality in 2020 than in the historical period likely have incomplete data. Another challenge is that the majority of counties in the study had fewer than 50 directly assigned COVID deaths. So, we're working with counties with relatively sparse data. And the demographic and structural policy factors that we examine are from data from 2012 through 2018. And finally, the counties included in our data set may not be generalizable to the entire United States. In conclusion, our findings suggest that the overall mortality burden of COVID-19 considerably exceeds reported COVID-19 deaths. We also found that the number of excess deaths not assigned to COVID-19 differed by county level factors related to socioeconomic disadvantage and structural racism. And when considering the addition of excess mortality not directly attributed to COVID-19, our work suggests that racial and socioeconomic inequities and excess deaths attributable to COVID-19 may be even greater than currently understood. Our next steps, and we're really interested in collaboration with other demographers and sociologists. We are making use of NCHS provisional county level data on COVID-19 and all-cause deaths by race and ethnicity to examine county level factors associated with excess deaths in the non-Hispanic Black and non-Hispanic white populations. We are examining geographic variation in excess deaths in the overall population by race ethnicity. And we hope to kind of decompose excess deaths not assigned to COVID-19 into the misclassified deaths and indirect deaths by taking into consideration spatiotemporal patterns of COVID-19 mortality. I would say that this last goal number 3 is the hardest to tease out, and really the challenge of our community is to figure out how do we determine which are misclassified deaths versus the indirect deaths. I think if we can solve that problem, we can really contribute to the literature. So I just want to end by thanking others for their generous feedback. We received really helpful feedback from Magali, Jacob, Dana Glide, Josh Goldstein, Michelle Guillot, Patrick Waveline, Anna McGregor, Jennifer Weave, and Wubin Shea. And of course, we thank the generous support we received from the Robert Wood Johnson Foundation for supporting this research. If anyone has any questions or ideas for collaboration, you can reach me at acstokes@bu.edu, and we have a preprint up which is available at this link. With that, I'll say thank you and turn it over to Dr. Crimmins. I think you're on mute.
Thank you very much, and perfect timing. Patrick Uveline has a question for you. Have you tried to estimate your beta coefficient with different cutoff for the end of the estimation period? I think it would talk to the issue of whether people dying from COVID were already frail with multiple other morbidities.
So I just want to make sure my collaborators have a chance to talk. So Sam, would you like to address this one?
I would like to hear the question repeated, Eileen, sorry.
Okay, so it's from Patrick Uveline, okay? Have you tried to estimate your beta coefficient with different cutoff for the end of the estimation period. He then comments, I think it would talk to the issue of whether people dying from COVID were already frail with multiple other morbidities.
That's interesting. So this equation has been estimated chronologically through the summer to up to November. The coefficient has actually grown somewhat, if I'm characterizing it correctly, rather than declined, as Patrick may be implying. So we also, as Andy indicated, we also did a sensitivity analysis when the data were most complete for counties where it was most complete, and that did not seem to make much of a difference in the estimated beta 2, the coefficient of COVID. So good question, and we should keep our eyes on that, certainly.
There is another question in the chat box. It is from Abate Mammo. Do you expect that the misclassification will be minimized when NCHS finalizes the data? This is
Irma may want to
Irma.
sound off on that.
Can you hear me?
Yes.
No, it's possible. I think there are some counties and some states where the reporting has been very much lagging, and some states may be updating their reporting, and there may be more deaths assigned to COVID than previously. I think also over time, the states are getting better at assigning the deaths to COVID as testing increases, for example. But I think we'll get a better sense when we have more data, including multiple cause of death data, where we can look at not only the underlying cause of death, but also the contributing causes to see how COVID is assigned as a contributing or an underlying cause of death. So I think we need some additional data, but it's possible, I think, to investigate this further once we have the multiple cause of death data.
Okay, we have another question, and I see that this group of authors throws the question to someone else when they think it's hard. Can you speculate on the implications of using nearly 2/3 of the US counties, though admittedly a far smaller share of the population? And this comes from Kenneth Johnson.
Sam, would you like to address that one?
So the counties that we've selected for analysis are counties that obviously have somewhat higher COVID mortality because we have a cutoff of the number of deaths. So they're somewhat unrepresentative of the US. The last time we looked, I believe it's the case that something between 60 and 65% of the population of the United States is included in the counties that we are examining. So it is not a complete count. And it's obvious that things are changing in the nature of the relationship between certain geographical features and COVID mortality in the course of the epidemic, so that the Midwest, upper Midwest is in particular being devastated in a way that it wasn't initially. So yeah, we certainly need to keep our eyes on that, and the analysis will be updated as more counties become available.
Yeah, and I would like to add to that, that as the pandemic is moving to smaller towns and rural areas, we may find there may be a differential pattern to some extent. There's a fast moving epidemic right now. So I think once we get the additional data, we'll get a better sense.
Giovanna, do you want to mention what's in the chat from John Wilmer?
Yes, I think all the panelists and the attendees can see that. That's in the chat box, and it is an invitation by John Wilmot of the United Nations to an announcement about the formation of a technical advisory group on COVID-19. So all of you can read, there is also a website, a link to a website. So I hope everybody can read it. It's a long announcement, which I invite everybody to look at carefully.
Thank you. So I think we should move to the third paper now. Christophe Guilmoto will talk about COVID-19 death rates by age and sex and mortality vulnerabilities of countries and regions in the world. So we're expanding our scope here. Giovanna is going to share the screen.
Yes, I'm sharing this. Hold on. Can you all see it?
Yeah.
Yes. All right. So, Christophe, tell me when to switch, or
Okay.
I'll figure it out.
Hi, folks. I'm very happy to be with you, especially after this very interesting presentations on the US. My presentation is likely to be far less detailed because I'm trying here to take a different perspective. So let me, next slide, will show you what I'm basically trying to do. My idea a couple of months ago was to map the death patterns of COVID-19 mortality. And I wanted to look at the role of the age distribution, especially for areas like sub-Saharan African countries. So what I did was to focus on available data and registered death. And here you have to bear with two of my assumptions. First, I will focus on the age distribution, what I call tempo, rather than focusing on the intensity of COVID mortality. And why is it that I'm doing that? It's because of my third assumption. I think that there is, of course, a serious issue of underreporting and, of course, indirect deaths caused by COVID-19 that we are not catching, but that the age distribution of deaths may be of far better quality and less biased. So my idea was to, let's see what they have to tell us, this data, however imperfect they were. And so what I'll show you in this presentation is first some of the results of what I did 6 months ago, and which is available. And then what I did a couple of weeks ago for this presentation, when I took the new data and I updated my database, and I did some of the stuff I had done before, but with a much better sample of countries, and unfortunately, many more deaths. So on the next slide, I'm just referring to the paper 6 months ago. And here on the next slide, you will see some of the results. So at that time, I had data from 12 different countries, mostly in Western Europe. And here you could plot the average. In fact, it was weighted death rates by sex and age, and everything had been reclassified. I reclassified everything by 5-year age group, and you could see a clear pattern, like for instance, excess male mortality starting from young adult age, and also a pretty regular pattern of mortality by age. But then on the next slide, I did the same for 3 different areas. The US, Latin America. By that time, I think it was only Brazil, because that was the beginning of the epidemic in Brazil, and then Western Europe. And while discussing with Brazilian colleagues, we noticed that the shape of mortality in Brazil was pretty different. The slope wasn't that steep, you know, and there were more deaths among the youth or among young adults, and less among people above, say, 70. And then also on the next slide, you will see something pretty strange. Please, yes, oh, it comes one by one. This is a sex ratio of mortality. Sorry, you have to, yeah, one more, and one more. I think that's all. And in black, you see the average pattern of the sex ratio of mortality and how it peaks at around age 50. But you find different, slightly different patterns for example, for the US and for Europe. But that was just the beginning of the epidemic. So next slide. So again, I did about the same thing, but there were many more data available. So on the next slide, you see the countries I selected initially, 35 of them, with more than 3,000 deaths by beginning of November this year. And I went down to Guatemala because it has pretty high COVID death rate. Now, unfortunately, among these 35 countries, data weren't available for all of them. So on the next slide, you will see that I had to exclude a lot of them. Luckily, I could sort of swap countries for one for another. For example, we don't have Russia, but we have the Ukraine. We don't have, we have India, but we don't have Pakistan. Pakistan is very, very sad because they used to keep very good statistics, but all of a sudden in October, they stopped publishing statistics by age and sex. So we don't have Egypt, but we have Turkey, like that. We don't have Bolivia, but we have Peru. The most unfortunate thing is that we don't have anything from sub-Saharan Africa, and especially I couldn't get hold of the data from South Africa, where, as you know, the death rate is pretty high. And but elsewhere, there are too few deaths from African countries for me to incorporate that in my data set. So on the next slide, you will see the kind of data that I've been able to use. So sometimes these are tabulations that are already prepared and published and available. Some of them are, for example, and it's fantastic, collected by my colleagues at INED in Paris. So you can see them in blue. Then in green, you see also countries which have published the entire data set of deaths by age, locality, date, or sex, of course. And that's mostly from Latin America. So it's fantastic. I mean, you have to download the data set and then sort out the data, but it's just fine. And in some other countries, you have some data that have been published and they are pretty incomplete, but I've still kept these data because they represent a part of the work that I wanted to be in my sample. Now, what do we get? We get data which are now in a different age format. Look, for example, at the data on the left for Canada or Belgium. You have a pretty broad age band, you know, of almost 20 years for the younger ages, and then it becomes 10 years. Whereas for the US, it's for 10-year age group. In fact, there are 11 different age formats for all these countries. And we also noticed that there are so few deaths below age 10 that it's pretty difficult to work on this age group. So that's why I'm not going to use it for the rest of my analysis. But here, I decided against converting the death rates into 5-year age death rates. And so I kept them as they were published. Or when you have the entire data set, of course, you can do whatever you want. Now on next slide, you will see finally what I got in terms of deaths. That is almost 800,000 deaths this time from 24 countries. So that means 4 times more deaths than 6 months ago, and twice the number of countries. And here a much broader variety of countries. There is no country in East Asia, mostly because for lack of deaths, because, for example, we have data from Japan or from South Korea, but the numbers are pretty slow. So I'd rather not, I decided not to include them in my database. But otherwise, with the exception, of course, of Sub-Saharan Africa that I've already noticed, we have now a much broader sample of countries. Now, on the next one, we will look finally at these death rates. So here they are for male population. So you have about 251 measurements. And if you look at the next slide, Giovanna, here, you know, it finally gets a little bit less messy, just because I've used the log of mortality. So you can distinguish a shape you're familiar with, of course, of a life table. And we know that we can go even further if we look at the data for individual countries. And that's what I'm doing on the next slide. So unfortunately, you can't see much. So here is for male. The next slide will show you the same rates for females. If you can look carefully enough, you will see that it's not always a straight line. Like, for example, look at Guatemala. You can see how that it's slightly non-linear. It's the same for Colombia. In fact, it's the same for a couple of Latin American countries, but I'll get back to that later on. So what we can do now with this on the next slide is simply apply a Gompertz model in which we will have on one side a factor related to quantum, to intensity of mortality, and another one, in red, alpha, which is related to the age schedule, the age pattern of mortality, sorry. And of course, it's pretty easy to model it, but I'll stick to the very simple model, Gompertz model, for reasons that you will see further later on, instead of trying to apply a more sophisticated modeling strategy. So on the next one, here is what you get for these 24 countries when you model mortality using this very basic. I mean, I'm doing it, as you can see. Oh, sorry, I haven't mentioned it on that one. It's only for the population above age 10, precisely because it's non-linear before for the population below 10. And then on the next one, on the next slide, this is the overall regression results that you have for my entire sample of countries. It's not that bad, you know, with an R-square of 96.96. And even when you club together male and female deaths. And you can see that, of course, male is a significant factor, accounting for about 50% higher mortality. But here it's in log. And here I do control for all countries. Now on this one, you see the country which was the first in my sample by alphabetic order, Argentina. And you can see that the correlation is even better, you know. This is only for the male population. And that you have clearly what I call the alpha, the slope of mortality, which is around 0.1. In fact, it's slightly below in that case. Now, going a little bit further on next slide, you know, we can look first at the quality of the modeling with the R-square for each country, and also the slope of mortality, the alpha, for each country. And first look at Mexico. Mexico, you'll see the correlation is pretty weak, you know, below 0.9. So, you know, maybe I should not have included Mexican data. Maybe I should have worked more on that, because there is obviously an issue. But otherwise, correlations are pretty strong. And you can see that the alpha tends to be higher for the male population. And you can see also that I've put it in bold, that for industrialized countries, the alpha is usually above 0.1. And in fact, that takes us back to the discussion, the initial discussion about Brazil, which had a lower slope, a lower mortality slope. So I wanted to go further with the, from that observation, and that's what I'm doing in the next slide. So now I'm just looking at the slope of mortality, these alphas. And I'm comparing them for my 24 countries, here only for male mortality, but that's about the same for female mortality. And I compare the slope of COVID mortality with two different indicators. On the left, it is with the mortality slope that I computed from the life tables computed by the United Nations for the last world population prospects. So it's alpha, the same alpha computed from the standard life table. And on the other, on the right, you have the same computation, but using life expectancy at birth. And you see pretty good correlation. I mean, not as strong as what we've seen before, but that shows that there is not only regularity in death patterns of COVID, but also of the shape, the age schedule. So we are not talking, once again, let me remind you, we're not talking about the intensity of mortality. We're just talking about the age distribution. So that's where I am at this point. Of course, I'm short of an explanation for this regularity, but that's one thing I want to work further on. Then on the next slide, it's I show you typically what would happen for two countries which are pretty different, Brazil and Italy. And you can see how the shape is way, the slope is way steeper for Italy. And then finally on the next slide, I have again average all the deaths by age. And that's on the left. And I've used this pattern, this average pattern of COVID-19 mortality to all countries in the world to sort of standardize the impact of COVID mortality. And I've found significant differences. Of course, some countries are way younger, especially in sub-Saharan Africa, compared to other countries in East Asia, like South Korea or Japan. And the impact in terms of death is gives me a factor of 26. So it's very important. Yet, when I use this, what I called initially the vulnerability factor, which is age structural factor, when I use that and regress it to what we have today in terms of overall COVID-19 mortality in the world among 180 countries, I find only a pretty weak correlation of 0.18. And it used to be stronger 6 months ago. So obviously the factor, the age structural factor is diluting. Now, the next slide is my conclusion that there is quite some strong regularity in this COVID mess. And the mortality is linear, but quite steep. I've not shown you, but it's much steeper than other mortality, than the regular mortality. That's why there is an age penalty of COVID for affecting the older population. That very shape or slope of mortality is related to overall life expectancy. That's something I didn't expect at the beginning. And that there are wide variations, in fact, not from 1 to 17, but it's much bigger due to age and also sex composition. Now, there are some challenges, stuff that I haven't done, and I welcome all suggestions or proposals. I want to include more countries from Asia, especially Pakistan or Bangladesh, and from sub-Saharan Africa. So I'm thinking of Southern Africa mostly. We need, I think, to understand the nature of regional variations in age schedule, like Mexico and Guatemala that I've hardly mentioned here. And something that I had no time to describe you, but which is in fact my primary interest, is the sex differentials in COVID mortality, which are so pronounced. So thank you very much.
Thank you, Christophe. No one has put a question on this paper in the chat, so I'll ask one. So Christophe, I'm really surprised at the similarity of the age pattern across countries. It's greater than I would have expected. I would have thought more would be due to differential exposure due to different things like differential living arrangements and differential caregiving arrangements at very old ages. And so it looks from the strength of that age relationship that we're really talking about something like a sort of senescence of the immune system that's occurring everywhere with age.
Mm-hmm. Yes, I can only agree on that one.
Okay. Other questions, comments? Something came up.
You find the slope of the relationship with age is lower when life expectancy is lower?
Yes.
And do you have, I mean, is that possibly a result of coding issues? Populations with lower life expectancy are poorer populations, probably with poorer vital statistics. Would you imagine there'd be some relationship there between the quality of coding at old ages, people dying of COVID, getting assigned to other causes of death, perhaps? I mean, that's one speculative possibility, it seems.
At this point, I think it's yeah, it's a good idea, but I mean, it looks like it's pretty regular. And there are countries, especially in Latin America, where the quality of age recording is pretty good. So now, if there is a bias in the declaration of COVID-19 deaths among the elderly, that is a possibility, but I would need to have more evidence to clarify that, to substantiate this hypothesis.
So I think this is a related question from Angus Deaton, who says there's been some speculation about temperature variation, either directly or indirectly, or because of living outside. Did you look at this?
No, in fact, I haven't tried at this point to find any outside factor like temperature or, I mean, exposure or islands, for instance, which are well known to have lower COVID mortality rates. Or no, I'm just looking at the demographic consistency of the distribution of deaths.
Mm-hmm. Any more questions, comments? See, initially in the United States, our older deaths were so concentrated among the nursing home population, you know, varied from state to state, but up to the level of 80%, 60%. Most states were very high then. So that's why it's somewhat surprising to me at that point that had been observed somewhat in Italy, but we were the only two countries that were extremely high in levels at that point. So I'm surprised at the regularity. So Elizabeth Thompson says, really, same in Sweden?
Well, I'm afraid, yeah, Sweden made it to my sample, not Norway, not Denmark, not Finland. And I can't go back on the statistic, but for Sweden, it's exactly the same shape.
Anyone else? Any more questions? I'll go back to a question for the people who worked on the United States from Terrence Hall, who said, does the disruption of the 2020 census operations have an impact on your analysis?
Well, hi, Terry. In fact, we're not using census data at this point, you know, but still a lot of countries have postponed their censuses, or except China, which is conducting it right now. Data collection systems are definitely disrupted. Yeah, that's a very good point. But here I must say that almost a third of my countries, the countries in my sample were from Latin America, where they have maintained what I see to be pretty high standards, sometimes even against their own governments, like in Brazil.
Well,
So,
I could say that the 2020 census data that we are using, I mean, for the estimates are preliminary estimates that are based on, I think, the 2018 revision and projected to 2020. So obviously the quality of the 2020 census is going to affect population estimates for 2020, but at the moment, we are not using 2020 census data, but projections from the Census Bureau that we were able to get under a special agreement. But yes, the 2020 census is a huge problem. Will be.
I see that there is a question from Eileen. Bonsoir, Eileen. And that's she addresses a very important point that I forgot to mention, is that, of course, it would be much better to be able to do like Andrew is doing, working on excess mortality, where you would catch, unregistered COVID death, as well as maybe indirect deaths. But I'm afraid we don't have that. We have that thanks to the human mortality database for a couple of countries, for some kind of weird age groups, but we do have it. And in fact, I've worked also on it, but it's mostly for industrialized countries. And, it doesn't cover Peru, it doesn't cover Turkey, doesn't cover, so, we are missing quite a lot of deaths from less developed countries.
And Christophe, I know that the first two papers are on preprint form. Is your paper in preprint form anywhere?
The one I prepared 6 months ago, but otherwise, no, it's just in PowerPoint form.
Where is can you share, are you willing to share these slides or the first paper you tell us where to find it?
Yes, it's somewhere, in a preprint. I don't even remember the address.
There was a question about
easy
that.
to find. Easy to find. I don't publish that much on COVID.
Someone asked whether this is being taped, and this is being shown on YouTube, and the YouTube video will be available in a few hours. Once it's downloaded, it will be on the PAA website, and you'll be able to access it from there. Any more?
Comment, can I make a comment on Noreen and Theresa's paper? It's actually a note that there has erupted a controversy about the IHME estimates of the impact of everyone wearing a mask in the pages of all places of the Wall Street Journal last week and this morning, a series of letters this morning. The commentator last week noted that Murray et al. Were using a prevalence of face masks of 50%, which gave an opportunity to double the impact of using face masks, whereas the person claimed that the actual prevalence was more like 80 to 85%. So you might be interested. It's not a dichotomy, obviously. It's a continuum of how frequently you're people using in public masks. Anyway, thought you would be interested in taking a look at it if you hadn't seen it.
Thank you. No, that is very useful. Their estimates have changed so much over the last few months overall, but also in terms of the impact of using masks.
Correct.
Yeah, but thank you for that, Sam.
So I don't know which one of you wants to answer this question, but Terrence Hull asks, across the world, what is the impact of COVID-19 lockdowns on the data collection systems? Or maybe that Christophe has already said something. Huh?
It was already answered.
Okay, sorry.
There's another one by, let's see here, got it. No, I lost it. There was another one by Mike McQuestion.
Yeah.
Oh, there it is. I found it. About harvesting. So harvesting did not occur. The proportion of frail individuals remained steady. COVID-19 did not reduce the proportion of frail in a population.
Well, here I can give a beginning of an answer because, of course, I thought of this. And one way to examine it was to divide death by sort of waves. You have had almost 3 in the US. We have had already 2 in France. So I tried to compare for the US and a couple of countries in Western Europe, a death before June or July, depending, and after June and July, to see whether there was a change in the death patterns. And that could be explained by some kind of harvesting process. And no, I couldn't find anything, but there was a slight change above age 85. So we're dealing with quite a large number of deaths, unfortunately, but small populations. So I think it's almost invisible. But that's just, of course, in the course of 6 months. So it's pretty short for the harvesting process.
I think if I might, it's worth pointing out that although some harvesting might be going on of very vulnerable people, the survivors of the epidemic are themselves being scarred, it's leaving a serious imprint on many people. So the net direction of the impact of COVID on other disease processes is certainly unclear. I wouldn't assume it's going to reduce mortality from other causes.
I think we're going to see effects for 100 years at some level. Do we have any other comments or questions? I don't.
We have John Wilmoth.
He's put a number of
links
to nursing homes.
Nursing homes. Yes, everybody can see them.
So I think it's time to end and to put up our next slide, Betsy, for December 8th. Betsy, Bobby? Well, so thank you, everybody. Today was a great success. These were nice papers. They went together well, and I think we all learned a lot. We're supposed to get up a slide right now on the last webinar from 2020 that will have one of the sessions that had been scheduled for April and at the PAA in person, and will now be on December 8th at 12 o'clock Eastern time. And it's called PAA Presidential Address Topics. Where are they now? So Sam Preston will do an encore appearance. And Jane Mencken, Arlen Thornton, and Barbara Entwistle will speak in that session. So Sam, we don't usually let people come on twice, but you are an exception.
You can prevent me. Be aware that I'm happy to be prevented.
Oh no, you're committed. Everyone wants to hear what you have to say now.
Yeah. All right.
All right, so December 8th will be our last webinar of this year. We look forward to it, and these are nice webinars to end with. So thank you everyone very much. And as I said, this will be up on with a link on the PAA website later today. So thank you. Bye-bye.
Bye. Thank you.
Thanks.